Okay, this is Kevin Luters, and we're talking to Dr. Santo and Dr. Cannon, both anesthesiologists from Anesthesia Hygiene, and we're going to talk about the areas of contamination that are caused by the environment. And specifically, we're going to talk about the SHE guidance that was sent out, and SHE stands for Society of Healthcare Epidemiology Association. And they came out with a document that was endorsed by the Anesthesia Patient Safety Foundation, the ASA, and the AANA. So CRNAs and anesthesiologists and the APSF all endorsed this SHE document. The document was released December 11th of 2018, so it's very timely. In that, their recommendations, they recommended two things that can affect us. One was they recommended specifically to use disposable handles for laryngoscopes, and then they also suggested protecting the environment using a barrier such as the product that Anesthesia Hygiene offers. So in essence, the way I understand it is the anesthesia machine and the environment in general is so fraught with potential infections that you want to protect the machine from the patient, and you also want to protect the patient from the machine. And the anesthesia hygiene cover helps in that regard. The first slide that I have up is this anesthesia hygiene that goes over 7 different published documents. So Dr. Santo was talking about that, and I'll let you continue now about some of these studies.
So yeah, as I was just mentioning earlier, people started focusing because there was heavy contamination of the anesthesia machines, and there was also a lot of time constraints from the OR side with regards to, cleaning the machine in between cases and optimizing the flow of or maintaining the flow of the OR between patients. So people, came up with all the laryngoscopes and alcohol canister, but really there was not much attention paid towards the anesthesia work surface. So that's where we came in as practicing anesthesiologists. We decided that, it's best to cover these surfaces, because even if you have clean laryngoscope and alcohol at your disposal, there's no guarantee the surface where you place them is going to be clean. So we came up with this disposable, drapes that can be used for we have two types of drapes. One is a small one, it's a tabletop, and the other one is a big drape that covers the entire machine. So just to keep your space organized, clean, and it also helps to stow away all the dirty equipment, for example, the yanker or the used laryngoscope. There have been studies in the past to show that this work surface is heavily contaminated. Randy Loftus, he's a practicing anesthesiologist who's done extensive studies about that, and we have shared some of his presentations and his work with Kevin. Kevin, you may be able to show it to them later. And also, Dr. Bernbach from has shown that the machine surface is heavily contaminated right after airway, that is after placing an ET tube or an LMA. So places that get contaminated and are routinely missed out during cleaning, because cleaning is effort dependent. It depends on the person that's administering or the availability of anesthesia tech. So these two drapes pretty much keeps the surface clean. So you protect the machine from the patient's secretion. So the machine is clean, and subsequently you have another patient, you don't transmit all the contaminated, the secretions from the mouth or the nose to the next patient or to the IV port of the next patient. We have 2 such drapes. One is a smaller one, as I mentioned. That's for really to keep the surface clean and for fast-paced cases, to keep moving on and to stow away your contaminated blade, scope, yankar in a very clean manner. The bigger drape is for the highly contaminated cases, like let's say patient has C. diff, VRE, MRSA, that you absolutely don't want to cross-contaminate between patients. So these drapes cover the whole machine, monitors, keyboards, and the EHR or the EMR. That way, everything from that dirty patient stays with that particular drape You take it off the machine and toss it. So
now,
these are
Dr. Murley was telling me that if a patient ends up going into a room that had MRSA before them or C. diff, the chances of them getting C. diff is like a ridiculous 50 to 60% chance. So it really is, the environment really is a problem, whether it be a hospital bedroom or an operating room. Is that correct?
That is correct. An operating room is often not looked into carefully. So that's definitely a potential carrier. You just have a bug sitting there. All you need is another patient, a viable human being. No matter what your glove is, or if you change gloves, or even if you use alcohol, if it's sitting there on the machine, it's going to go to the next patient.
The other thing Dr. Murley was telling me is that a lot of the infections, for example, it was fascinating to hear about, we all know, or most of us know, that when they're doing a total hip or a total knee, the surgeon will be double gloved. They'll have a spacesuit on and a helmet, and they have special laminar flows of airflow, and they won't let the door open more than 2 times, an hour, and you can't come in and out. So there's all kinds of things that they're doing, but it's come to light that the infections that are going to the joint may be caused by anesthesia, in the fact that they might touch their APL valve and get a bacteria on their hand, and then they're touching a syringe, and then they're drawing up a drug with a needle, and then they're taking that vial and that needle and touching a stopcock that they may have touched earlier. The net result is the infection and the bacteria is being injected into the bloodstream. And what Dr. Murley was kind of explaining to me is that the areas around the knee where they did a total knee are all blood clots, etc., and that's where these bacteria will basically grow, and they'll literally have a party there, and that's what ends up causing the joint to get infected. So here the surgeon is focused on making sure there's no cause of infection on his part, and the anesthesiologist on the other side of the drape, he has no control over what they're doing. They are not sterile. Would you comment on that, Doctor?
Sure. You just nailed it, actually. If you think about any OR, the surgical side is absolutely sterile. They have, they have drapes, they have covers, all their equipment is sterilized. But on this side of the drape, from the anesthesia perspective, we are not sterile. Even the ET tube, some people just take it and leave it on the surface before using it for a procedure on a patient. So surgical experience, as it is an immunocompromised state. You're under a lot of duress. There's a lot of stress. So there is immunocompromise, and along with that, if you continue to, let's say you had a patient with C. diff or VRE before a joint, which is not the ideal situation. People don't usually do that. But if it's a busy practice, it can happen. We have seen that happen. So there is probably an infective organism lingering around in the anesthesia work surface. We call that AWE, or anesthesia work environment. If it's not cleaned properly and you have a joint patient, it's a multimodal step. It's not just one step. It's clean hands, clean surface, clean IV ports. Now, if one thing is contaminated, obviously for an extremely sterile procedure, us on the other end, we are injecting a port with a potential contaminant or a bacteria. And sure enough, the bacteria goes into the system. The body's going to try and do everything it can to try and attack the bacteria. But the surgical site, which often terms is called SSI, or surgical site infection, is a very viable site, because that place has been cut open. The immunity in and around that area is already compromised. And you have blood clots, which is a great medium for any bacteria to grow. And boom, you have an infection right there. So it's a few steps. It's not just one. But if you think about it, one side of the drape is completely sterile. And the other side of the drape, we just don't care, because we don't have the time or we don't have the personnel to help us out maintain all the essential steps that is needed to carry out what we normally do in a very clean way. And people don't, there are nurse anesthetists, anesthesia technicians, and MDs. The problem exists across the board. Now, if you go to an anesthesiologist and say, hey, what you're doing is completely wrong, he's going to, fire back at you. So there is going to be a different modality to try and say that these are the studies proven and your side of the drape is completely, unsterile. So it's time to revisit. And we have the guidance from the SHARE document from December. And, these are the guidelines that are being recommended, and soon this will be implemented. So it's a bundle approach. Like how your disposable laryngoscope helps, also this disposable drape helps to keep your work surface clean.
Could you explain a little bit about, like one of the studies that's on this page right here talks about fecal patina in the anesthesia work area. And I hear the word fecal, I'm thinking of, poop, but there's basically the patient themselves can emit. So basically what Dr. Murley said to me was that every time the anesthesia provider touches their patient, whether to put an IV in or to intubate or et cetera, they could be getting, every time they touch the patient, they literally should wash their hands, which would mean they'd have to wash their hands every minute because they're constantly touching their patients. But what does that really mean, fecal patina? We're not really talking about poop, are we?
It's done by Dr. Perez. I think she's from So what happened is when we intubate or take care of a patient, it's not just the secretions of the skin flora of the patient. You sometimes put in an NG tube. Patients can be obstructed, or even as a provider, I can run to the ladies' room or the restroom in between cases and may not have ideally washed my hands with alcohol the way it's supposed to be. So they have found that even they have found, or she has specifically found that the machine is contaminated, and not only is it contaminated with the regular flora or the oral secretions, it also has fecal material. It could be from the patient, it could be from their OG, it could be from the NG, or it could be just from a lot of vomiting that the patient had that, contaminated the provider with their gloves, or it could be from the provider itself, which we don't want to mention because, people don't like to hear such things from us.
Now, Dr. Santos,
from the patient's own flora, from the skin, from the mouth, from their vomiting, or a contaminated GI procedure, abdominal, obstruction, a colectomy.
So once again,
those are the cases that have a very high rate of these fecal contaminants that can come on from the patient to the anesthesia work surface.
So
and
once again,
the second part of it
Miss, can I talk?
Said,
Miss,
for every touching the patient, you have to have the anesthesia provider should wash their hands. Is that possible?
Could you explain a little bit what
as a practicing anesthesiologist, I can say that it is very difficult.
Dr. Santos. Dr. Santos.
With alcohol, I'm not sure. Do I have alcohol? Not all at all times. So there are logistics, in the flow of the specialty and also availability of things. And if things have to be done quickly, there is no time to wash your hands. So we just go with the flow and use gloves and continue.
May I interrupt for a minute?
Hey,
I'm so sorry. I didn't
Kevin,
even...
I'm here, guys. Sorry about that. Yeah, Sushmita, they were trying to get your attention. Go ahead, Kevin.
All right. My question is, can you comment on what the words contact isolation cases? Because one of the things that we talked about was you have a patient that is isolated in a hospital room, and then they go in for surgery, but they call it contact isolation. And every time someone goes in there, they got to drape up, and every time they leave, they got to take the drapes off. Could you talk a little bit about contact isolation cases?
Murli, go on.
Okay, so basically the term contact isolation is utilized in a situation when the patient has pathogens or bacteria that is resistant to multiple drugs, and since bacteria primarily spreads by contact, they want to isolate the patient so that people touching the patient then don't go and touch other things, and thereby that's the term for contact isolation. And usually when that is emphasized, most hospitals now have some kind of flagging up system, wherein when a patient like that is coming to the operating room, there are special protocols in the OR in most hospitals, wherein they would wheel the patient directly into the operating room and limit contact with other areas of the hospital from that particular patient.
Okay. So in my experience, the contact isolation could be as little as a cold, but it could also be that they have something like very much that we would be concerned about, MRSA or VRE.
Yes, usually in the OR, it is for multi-drug resistant organisms, so MRSA, VRE, C. diff, also in things like they call multi-drug resistant E. coli. So there are different pathogens that they use this terminology for, but not just common cold or flu.
Okay. Now are you on computer? I have your PowerPoint up. Do you want to talk a little bit about the page that shows published evidence, or do you want me? Are you not at your computer?
I am not at my computer, but I'm just opening in on my phone, and
okay,
I
can tell you what we're looking at. Is we're looking at the first page that shows 7 different studies. One's a fecal patina. One's the dynamic implications of bacteria transmission. There's transmission. You know, is there anything specific you want us to know about those studies, or is it just basically this is the idea that infections are caused by the environment and anesthesia has a terrible environment?
Right. So basically, what the single message from all these studies is that the anesthesia environment is a contaminated environment, and what all these studies indicated also was that when a patient comes into the operating room and the pathogen that the patient has, in this case, let's say a contact isolation patient, so a patient has C. diff. The C. diff goes from the patient to the anesthesia environment, and then it goes to the next patient. That has been documented clearly by many of these studies, and over and over again, the 7 studies that you see being listed there, in some capacity or in different capacities, they actually proved beyond any reasonable doubt not only gets contaminated, but also that acts as a reservoir for contaminating subsequent patients. And when it was just the anesthesia machine, it was one thing. But now with the advent of EHRs, there's keyboard, there's the mouse, there's the touch screen. So multiple surfaces on the anesthesia environment are getting contaminated, and this has been shed in the spotlight by these studies.
So now the issue here that we should be aware of is that these studies all support the SHEA guidance that was just announced December 11th, 2018. So perhaps we should talk a little bit about that, the significance of that. And what I expressed earlier is how important it is, in my opinion, that the Anesthesia Patient Safety Foundation, the ASA, and the AANA all supported the SHEA guidance announcement.
Correct. So these studies basically were the ones why the SHEA guidance actually happened. it was when it was a one isolated study, it was not really picked up. But then when several studies proved, and remember, all these studies were done when the anesthesia machine underwent what is known as routine cleaning as per existing protocol. Okay? It was not done where to prove a point that, the machines, they didn't clean the machines. They actually educated, in all these studies, they educated the technicians to clean the machine, and the technicians and everybody knew that the machines are being cultured. So all these studies indicated that.
Yeah, we've lost you. I know. At any rate.
And it was only because
you're in a bad spot. We're not hearing you.
Murli, hold on. Murli, we lost you for quite a bit. Yeah.
Yeah. In the future, when we do one of these things, don't be on a cell phone, please.
Okay, I'll try to remember that.
Yes.
But so basically, what I was trying to say was all these studies were done with institutions cleaning their machines and educating the technicians to clean the machine. Of that, these studies documented all these findings. So the SHEA guidelines was prompted mainly because they noticed that the current protocols is not enough and we have to do more. So that's why the SHEA guidelines have been published, and it's been supported by all the societies.
And not only that, Kevin, just to add to that, there's also a steady rise of contact isolation patients that we see in the hospital setup. There's more and more of these patients with VRE, MRSA, and a lot of drugs. A lot of patients are also getting resistant to all the other existing available drugs. So those contact isolation cases are on the rise, and surgical site infections are on the rise at some facilities, where they do not, follow significant proper protocols. So everything in unison, we have to make a conscious effort to keep the anesthesia work surface cleaner to prevent cross-contamination between cases.
What does SCIP measures mean?
So SCIP is basically surgical continuous improvement program. It was basically, it's not surgical, it's actually SSI, continuous improvement program, and it was it's a movement by, or it's a protocol by CMS, the Center for Medicare and Medicaid Services, which basically showed a bundle of measures, which included cleaning the patient, maintaining normothermia, checking blood sugar and controlling blood sugar, and I think it has 7 measures: antibiotics, administration of antibiotics, clipping the patient instead of shaving the patient. So there are 7 measures that SCIP was actually put in protocol, and every hospital right now has to check off that they properly followed all these 7 protocols, adherence to all these 7 measures. And the thing is, as per the national patient safety goals, in spite of the SCIP protocol being done, the surgical site infections haven't been brought down. And now they are moving on to other potential reasons why patients are getting infected, and one of the spotlight has been the anesthesia work environment.
Okay.
So it's a surgical care improvement program. That's what it is, and it starts pre-op, intra-op, and post-op.
Now, the slide that I have up right now just shows that the anesthesia work environment is the biggest cause. So in the environment is the biggest cause, but it also mentions hand hygiene, patient flora. And the patient flora, once again, is the idea that every time the anesthesia provider touches the patient, there's bacteria on that patient in their mouth, etc., and that's what contaminates the whole area.
Correct. So that slide that you're seeing, Kevin, that everyone is seeing right now, basically when they identified amongst the various sources, potential source of infection or potential source for a pathogen, they said it can come only from three places. One, it comes from the patient. One, it comes from the environment. Two, it comes from the environment. And three, it comes from provider's hand. And it quantified which of these things are really the main culprit. And most of the time, the patient's own flora is a smaller part of it. The provider's hand is in the middle, but the immediate environment is the major reason why a patient gets an infection. That's why that circle is the largest amongst the three, with the patient flora being the smallest. But obviously, at some level, there's an interaction between the three, and that's why you see the circles overlapping.
And obviously, if the environment is contaminated, that's going to contaminate the user's hands. Exactly.
Okay. You cannot wash your hands if the environment is contaminated. Exactly.
Even if you're gloved, you're going to, your hands may be clean, but if your gloves are not clean, if it's contaminated from the work surface, you're going to pass it on to the patient.
Now, I've switched the page to showing a picture of the anesthesia cover that's over the entire machine. And it has a research article here that says, assessing a novel method to reduce anesthesia machine contamination, observational trial. Now, you also got written up in Anesthesiology News, and I sent that out this morning. Is this research article what then got published in Anesthesiology News?
No, this research article did not get published in Anesthesiology News, but this research article was done after people saw our article in Anesthesiology News. And this was an independent trial that was conducted by the University of Virginia, where they purchased our covers and then used on their machine. And it was basically to do two things. One was to prove that you can put a cover on the machine and continue to work the machine and can do it safely. And two is, what is the level of reduction in the contamination? And that's what that study showed. Actually, it was the first study that quantified what level of reduction can be achieved using a cover.
Good.
And it was an independent trial, so it was not a sponsored activity.
So what's the article that's in Anesthesiology News? Is that something that you wrote, or that?
Yes, that is correct.
So the article in Anesthesiology News was when we presented our solution in the Society for Technology for Anesthesiologists in San Diego. There's a society like that which asks for new ideas, and they invite you to present your ideas. So we presented a poster about our idea, and it got picked up by the Anesthesiology News in that conference.
Okay, good. And the results of this study says there was a statistically significant reduction in CFU, which is cultured colony forming units, density and diversity when the anesthesia machine workstation was employed. The conclusion.
Correct. So what they're trying to say, sorry, I didn't mean to cut you off, Kevin, but what they're trying to say is not only the amount of pathogen of a single species reduced, but the number of different species of pathogens was also reduced. So the density and the diversity of the colony forming units was reduced. That's what it's saying. It's concluding.
Okay, good. Now the next slide I put up is the slide that I think is most important because it's an excerpt from the Shea guidance direction. And what I think is most important is the first paragraph that says this was developed by representatives from SHEA, the ASA, the APSF, and the AANA, which is really all those anesthesia bodies. So basically this is kind of a consensus guidance statement, and it basically specifically says that disposable covers should be considered.
Correct.
That's correct.
And go ahead, Pushmita.
So all the problems that we talked about, work surface, equipment, provider, patient. So all this has been shown over and over again to be, the causation for cross-contamination. So they came up with this, guidance which summarizes that these are the steps that are needed to effectively keep the anesthesia end of the patient safer and cleaner for, minimizing or reducing the risk of cross-contamination and preventing surgical site infection. So, we talked about both sides of the drape. One side of the drape is all clean and sterilized. The other side is not. This guidance effectively says that, starting from anesthesia machine, the provider cleaning and the patient, not using the IV port more than once. So maintain all this bundle in place will have a good outcome by minimizing the cross-contamination.
So I guess in a way, by putting a cover on the gas machine or the anesthesia machine, we're going to minimize the amount of cultures and the diversity of the bacteria. We're not necessarily going to protect the anesthesia provider completely because he's got to touch the patient and he can get something from the patient, and thus that could be transferred to a vial or whatever, or even a syringe. But by putting a cover on the machine, we at least minimize the machine's effect on the environment, correct?
Correct.
Yes, and with regards to that, there is one of the studies that shows that, the first case of the day,
We lost you. The first case of the day is what?
They started culturing the anesthesia work surface, and after subsequent cases, the CFU or the bio overload on the anesthesia work environment progressively increased. That is, after the last case of the day, the CFU of the pathogen or the organism was significantly higher than the first case. So yes, if the machine is, continuing to get dirty, at the end of the day, the patients may just get the organism from the machine can go to the next patient. So yes, in a way, we are protecting the machine so the subsequent patients don't get the infection.
Okay, one of the things I want to discuss is some of the questions that my sales reps might want to ask an anesthesia provider. So let's say if I'm meeting with an anesthesiologist and I want to talk to him about this, our basic way to do it is to page through our sales catalog, and we have toward the end a picture of the anesthesia hygiene drapes and the anesthesia organizers. So when we get to that page, what we might ask the anesthesia provider is, what are you doing now to protect the anesthesia machine and your patient when you have a known infectious case? Is that a good question to ask?
That's
For
a
sure,
great
yes.
question to ask, Kevin.
Yes.
That's a great question to ask, and that could lead into further conversation about what they want to, if they have awareness about it or not. That could be a starting point, but it's a great starting point.
What might they answer if I said that to somebody that's not using the cover, and I said that, what are you doing to protect the gas machine? They might just say, well, we're washing it down between cases or wiping it down. What would they say?
The tech might clean it in between cases.
Right. So, what I think you should ensure when you're talking about the big drape is basically narrowing it down to contact isolation cases. So, usually they may say we wipe it down. They may say we do it at the end of the day. It's not a problem. We have a separate OR for this. We don't see many contact isolation cases. These are some of the usual response you will have. By one measure, I can tell you all the above statements that I just mentioned is because in the real world, we notice this every single day. You may not have a specific OR. You may have to use another OR. You may never be able to wipe it down. There are no monitoring logs or cleaning logs for this. They may say, we don't see this often, which again means that actually they're not really looking into it because they may have at least, they may have at least one or two a day. But if you have to realize that the awareness may be different and your audience, depending on who the audience is. Because if it's an anesthesiologist who is not really involved in cleaning the machine, they may not really be worried about it or aware of it, but the tech may be more aware of it. So you may have to tailor your message depending on who you talk to.
So we could say maybe we could couch the question like this: for contact isolation cases, are you aware of the SHEA endorsement of anesthesia machine covers?
I would be careful saying SHEA's endorsement of a company, but what you could say is, hey, in the light of the new SHEA guidelines regarding infection prevention and anesthesia environment, do you guys do anything specific for contact isolation cases?
That sounds good to me.
Correct, so that we don't get into a gray area that an organization is promoting our covers, which they are, but we don't want to say it out like that.
Okay, we have about 30 to 40 people on this call. I'm sure there's some folks out there that have a few questions, so I'll open that up to the floor, and then you two physicians, if you have any other comments you want to give us, we'd be happy to hear about it.
Absolutely.
Hey, Kevin, this is John. The question I have is, there's a process component of changing the process of what they're doing from the anesthesia. Then there's a cost component. If this is in a hospital environment, who would be responsible for purchasing those covers?
That's a great question. So, okay, go.
So, John, it works in two ways. Sometimes, at least from our existing customers, what I can tell you is it can come from the anesthesia budget. Sometimes it comes from the OR budget. So the buyer for the product could be either of these two people. It could be the lead anesthesia technician who would order those products, or since we have some generic products like keyboard covers and screen covers that we've noticed other departments are also interested in using, like the ICUs, the OR buyer and then even the central buyer have been involved in purchasing the products.
Specifically, John, the perioperative director is the OR purchasing in charge. So the anesthesia tech typically goes to the periop director, and he can initiate from his end. And for the, like Murali mentioned, for the ICU, the generic products, that will be the central purchaser from the overall in charge.
I have a question.
Thank you.
Can you hear me?
Yes.
Yes,
So,
I can.
I can imagine anesthesia oftentimes, like you mentioned, when we're going through the catalog, almost brushing this off and saying, oh, we're watching the machines, we don't see many of these cases, but I understand the anesthesia techs may be more involved with this, but are there other areas of the hospital that we should be calling on with this product, like inspection, anywhere like that they may be even more interested in ensuring that they're doing the right thing as far as hygiene?
Definitely. So infection control is definitely a good place to also showcase the product, because eventually, even if the anesthesia tech and the peri-op director want to explore this, the next step is for them to take it to infection prevention or infection control department. And they are part of the value analysis. So it's always good to involve the infection control person or the RN or the MD or whoever is the lead on board. So it's a general consensus, and it doesn't depend on just one person or one department.
Well, another place you can call on, some of our reps actually do some orthopedics, or they might have a relationship with a orthopedic surgeon. I think that should be a place that they should at least inquire, say, because an orthopedic surgeon who's doing total joints, they're so concerned about infections and what's causing their surgical site infections, and they may not be aware of this SHEA guidance announcement. And if I was a total hip surgeon or a total knee surgeon, I would demand that my anesthesiologist and CRNA get their act together and cover that machine and double glove and do all kinds of things, because they're the easiest person to say, hey, you ought to do this, or tell the OR supervisor this should be done.
Absolutely, yeah.
You're right, Kevin. The surgeons are an important drivers as well. And what I would like to say is your proponent or supporter for this product could come from multiple places. And like, for example, at another facility, the IT department became a proponent because they said, hey, we can't seem to keep replacing the touchscreen because everybody complains that the touchscreen stops working. And most of the touchscreens today are not compatible with the cavi wipes that they use to clean the monitors. So that destroys the touch sensitivity of the screen. So they are also wanting the screens to be protected, and it has come up at several hospitals where JACO has come and asked, how do you clean the touchscreen? So with the advent of EHR, we are having all kinds of opportunities present to us. So when you are making a call at the hospital level, I would encourage that the SHEA guidance article will readily, receive the attention, because it's really going to be a matter of few months before the AORN picks up on this, and they're going to come up with another set of guidelines. So it's going to start snowballing within a couple of months into other organizations jumping on this. So when you go to the hospital, apart from going to the tech and the anesthesiologist, the OR nurses, because they all wonder about their keyboards and whether they can do something for the keyboards. PACU nurses, they want to cover their keyboards, and then the ICUs, infection prevention, IT. So there'll be so many calling points, and GI labs are some of the biggest places where you will have immediate traction for products like this. So you may spend about 2-3 hours meeting potentially 10 buyers and getting a quick sale.
Why is the
like
GI
mentioned,
lab more where you're having immediate success?
What is that, sorry?
Why are you having success in the GI lab, or earlier success in the GI lab?
That's for the smaller drapes and the keyboard covers, because it's highly contaminated. The scopes, the colonoscope and the esophagoscope, they go in and out of the patient's body, and a lot of times we also have significant contact with patients' oral secretions. So if you have like the keyboards and the screens that you also have to touch in between the case or during the case, it becomes very difficult to protect those surfaces. So the smaller products, the keyboard covers, the screen covers, and the AH11, the smaller drapes, are, the GI lab is a great place to start off with these products.
So I have a couple of questions. How long have you had this product out, That would be my first question. My second question is, at this point, how many facilities, being either medical centers or ASCs, have adopted this?
So we started the project at the company in 2013, and we went through several prototypes, and before we refined the final product, it was about 2015. And then since 2015, we have been, the first study, if you notice, came out in 2017 utilizing the product. And then we have, since then, big university systems have been our customers. So one of the early adopters were the Cornell Medical School Anesthesia Department in New York. They were the first ones to buy it, and so we are in New York Presbyterian system. And they basically started using it for their prion diseases. I don't know if you know prion diseases. It's a specific neurological disease that is also called mad cow disease. It is where it's like Ebola. You cannot decontaminate anything. So all the surgical equipment that gets utilized for this case will be thrown out because you cannot sterilize this equipment. And they had a few cases, and they didn't know how to deal with the anesthesia machine because it's in patient secretion, this protein particle. And so they started buying our covers to protect their machines because before the covers, believe it or not, they basically put a trash bag liner on the machine to protect the machine. And they were really excited that they could finally use something. Now, this was about 1 to 2 cases a month, so not a very large volume, so to speak, but obviously it became a segue for a greater adoption of the product into contact isolation cases, became the next obvious pit stop. So our current customers include Cornell, Mount Sinai Medical Center in New York, and then we have University of Washington, Seattle. We have the Queens Medical Center. Sorry,
how did you sell it to the? That was me. I'm in Seattle, and I call on the University of Washington. How long have they had it?
So, believe it or not, the second author of the Shea guidelines and the leading anesthesiologist in this article, Andy Bowdle, is a very good friend of ours, primarily because when he saw the product in 2015, they said that they're going to use it for every case because he said, it's no way you can clean this machine. It's got to be used for every case. And we basically said, okay, let's start slowly because we want to take it one step at a time. And so right now they are looking to push the smaller drape because the bigger drape went into a little bit of a resistance with the department. So they are pushing the smaller drape in their value analysis as we speak. But that's one of our customers. Queens Medical Center in Hawaii, they bought the big drape, and they bought the big drape because they had a spike in infection in total joints. And their anesthesiologist actually goes around the country talking about this problem, and we ran into each other at an ASA. So they have started using the big drape for their contact isolations and total joint cases. And then we are currently being sold by another distributor who has been pushing this product along, but nothing like you guys. We actually, being anesthesiologists, we hit the streets, being vendor-made certified, and I go for in-servicing. And I was in Hawaii last month to do an in-service for the big drape. So we have, those are some of our customers right now, and we are in talks with a few big customers for our screen covers. It's still in the works.
Actually, and for these are the main university hospitals, like Murli mentioned, and the other distributor also has consistent sales with some of the surgical centers in New York and in California that have been consistently buying the smaller drapes.
Yeah, Jim, the other distributor they're talking about is Sharn, the catalog company that uses telemarketers to promote the product.
Oh, okay.
So we do not have this product exclusively, but we have it everywhere. So we can sell it wherever we want. So there's no exclusive territories where we cannot sell it, but there is another company that has had access to it and has it in their catalog. The key thing to be aware of is that it wasn't until December 11th. I don't always care and want to be the very first person to take on a product line because it does take 2 years, maybe longer, 5 years maybe, to get some kind of recognition. But to have this December 11th, 2018 endorsement of a cover, not necessarily Anesthesia Hygiene's cover, but of a barrier, is a huge endorsement to the whole concept of covering your anesthesia machine. And that's what could launch this product to a whole nother level.
Okay. Let me ask another question. Do you know whether Harborview, which is...
Hey, Jim, we'll take your particular accounts at a different time. We only have about 5 minutes left.
Okay.
I will connect you with them, and you can actually call them directly.
Okay, great.
Doctors, do you want to say anything? We have a couple more minutes left to kind of summarize what you'd like and what you would recommend us do.
Whatever you've said.
Go ahead, Serge. I'll follow you. Go ahead.
Whatever you said with regards to the sales pitch is actually pretty good. You might find resistance with the bigger drape. The only thing I would like to say for that is it's a little bit of an adjustment, and if you know how to apply and use the extra slack on the drape, it'll be easy to use the machine. That's the key for the big drape. The small drape, it's very easy. It keeps your surface clean and organized, and to throw away your dirty equipment. So pretty much that summarizes both the drapes.
One other very important question is
yeah.
Are these drapes patent pending?
We have a design patent on it, and it is patent pending.
Okay, great.
So I just want to say that. Go ahead.
Go ahead.
Well, one of the things I'd like to share with everybody, if they're not aware, but I was involved with a drape company that came out with a product called the Sea Armor Drape, and I was the very first rep. And there were some companies that tried to knock that off, and the company prevailed. And so patent pending is very important. The second thing I'd like to mention is that same company came out with another product basically to cover the back table and any basins. And for the first couple of years, the AORN, they didn't feel that was important. Well, about a year ago, they basically almost mandated it. So I think you have a strong story. I think timing is great, and I look forward to selling it.
Thank you.
So I want to just add this. One of the easiest way to begin a conversation is also if talking about the obvious keyboards and the screen covers. If you find that the people may be skeptical about the anesthesia machine, so I will leave that to your judgment. But what I want to say is, I want everyone to know that we believe in partnering for the long term and supporting each one of you guys. So if you do have a customer who is interested in the big drain and you want us to come over to your to the hospital for a demonstration or an in-service, we are more than happy to come over there and stand with you and participate in the in-servicing. So I just want everyone to know that you guys are not alone in this, and we are more than happy to do everything possible to push the product in.
Okay, great. Thank you.
Okay, I guess we're almost at an hour. We are at an hour, so let's conclude the meeting on the anesthesia hygiene. Thank you both physicians for being on. And if you don't mind, I will pass on your names and email addresses to our sales team so that they can send additional questions to you. But
absolutely.
I think the essence of it is with this Shea announcement so recently, the time is right for the product. And the more you think about the potential infections that are going on and the fact that the anesthesia provider really hasn't changed their practice in numerous years, I think the timing of the product is correct. So we look forward to working with both of you, and I'll send out follow-up questions or messages to everybody. Thanks, everyone, for being a part of the meeting today.